Now we are going to talk about normal CTG interpretations, through which we will take you through the NICE guideline and we will explain what is the normal CTG. As we mentioned before, not finance, not strategy, not technology. It's a teamwork which can reach to your achievement. Labor room, you cannot work alone. You have to work as a team. Intrapartum fetal monitoring is essential for the identification of fetal hypoxia to reduce the perinatal morbidity and mortality. Remember that electronic fetal heart rate monitoring led to reduction in the rate of neonatal seizure, but there is no significant difference in the Apgar score in ICU admission and perinatal death. Subjective and incorrect interpretations of cardiotocographical data is a common finding in intrapartum events-related asphyxia. Why? Either the people they are failed to identify the abnormality, which is lack of training and exhaustion, overnight working, or is they identify the abnormality but they fail to act according to that abnormality. Risk factor mandating electronic fetal monitoring like maternal factor, labor factor, and fetal factor. In the maternal factor, there is antenatal factor like maternal comorbidity, hypertension, preeclampsia, diabetes, antepartum hemorrhage, other maternal disease like cardiac disease, severe anemia, hyperthyroidism, vascular disease, and renal disease, or intrapartum like vaginal bleeding and intrauterine infection and epidural analgesia. Labor factor like previous cesarean section, prolonged membrane rupture, induced labor, augmented labor, and hypertonic uterus. Or fetal factor, which can be antenatal like small for gestational age fetus or growth restriction fetus, prematurity, oligohydramnios, abnormal umbilical artery Doppler, HRH isoimmunization, multiple pregnancy or breech presentation, or intrapartum like a fetus who have a meconium stain liquor or suspicious fetal heart rate upon admission or post-term pregnancy. There is a good practical notes where you have to see. Look, first of all, like what we mentioned in the previous lecture, you have to identify your paper. You have to know what is the meaning of each cubicle. Is it 10 beat per minute or is it 5 beat per minute? Because will be reflected on the variability. You have to know what is the 10 centimeter. Is it 1 cube? It is 1 centimeter, or it is 2 cube is 1 centimeter. You have to know the speed of your paper, and you have to know, is it 1 centimeter per minute or 3 centimeter per minute? Remember that 1 centimeter per minute, it is the standard of care. 3 centimeter, a lot of healthcare organizations, they are follow, but I don't prefer because it will be difficult to interpret the variability. Date, time, name, hospital number, it should be there, and note any intrapartum event like vaginal examination, epidural or fetal blood sampling should be noted in the CTG, whether this CTG is a paper or electronic CTG. Document the CTG every 15 to 30 minutes in the first stage of labor, 30 minutes, second stage of labor every 15 minutes. And here, where we are talking about the importance of teamwork, you will tell me as a physician, I cannot document it every 30 minutes. I'll tell you, okay, I did ask you as a physician, obstetrician to document every 30 minutes, but there is a midwife, nurse who's sitting there. You train her. She should document it. There is a partogram. You should document it in the partogram. I mean, as a team. The fetal heart rate should be stored securely with a woman medical record. Here is an example of the paper. You can see the red one in the right and the green one in the left. If you look deeply to each cubicle in the green one, you will find each cubicle is counting for 5, not for 10, whereas in the right, each cubicle is counted for 10 beats per minute. And here is the importance of identifying your paper, because if you fail to identify your paper, and this has happened with us once, the purchasing, they change the paper without informing us, and we end up by increasing the rate of the cesarean section due to reduce variability. And we noticed that why a lot of our patients, they are coming with reduced variability in this week. We ended up, most of our patients, they are ended up by cesarean section. So when we review, we find that the paper have been changed, nobody informed us, and the physician, they didn't notice that this paper is changed to instead of being 5, it's changed to 10, and this is make a difference in the interpretation as reduced variability. CTG sticker, there is some organization that, like Royal Australian and the New Zealand College of Obstetric Gynecology, they did their own sticker for the CTG, so the midwife or the doctor, they will just click on it. This is available also in electronic file, and I think it is a good idea, and it can be we can mimic this idea to make the life easier for the physician, the obstetrician, and the midwife. Aim to from admission CTG to improve the prediction of what? The number of the cohort study and case study suggested that admission CTG is important to predict neonatal acidemia, term neonatal encephalopathy, long-term neurological impairment, and death. So our aim when we are doing admission CTG is to identify the fetus at increased risk of intrapartum hypoxia. So every patient admitted to the ward or to the labor, they have to have admission CTG, even low risk patient. Normal fetal CTG, we said that if this CTG is normal or white, that means this fetus have a good neurological integrity. They have no significant hypoxia or acidosis. So to identify normal CTG, we have to look to the parameter which we are looking for is the fetal heart rate baseline. It should be between 110 and 160. There will be normal variability, and there should be no deceleration or early deceleration or variable deceleration without concerning characteristic less than 90 minutes. Presence of acceleration is a reassuring feature, like acceleration should be 2 within 20 minutes, and if the patient not in labor, but if the patient in labor, don't consider absence of acceleration in the interpretation of intrapartum as abnormal, since the fetus in labor, they have passing through a transient hypoxemic stage, and they will stop moving, breathing, blinking to conserving the blood for the vital organ. So absence of acceleration during labor is not considered to be significant, where the presence of acceleration during labor, it's considered a good reassuring sign. Important information you have to remember that although the baseline fetal heart rate between 100 and 109 beats per minute is non-reassuring feature, by continue usual care if there is normal baseline variability and no variable or late deceleration there. Particularly in special patients who is post-term or patient occipito-posterior position, usually they are having a low heart rate, but you have to be sure that the variability is intact and there is no deceleration. And remember that the concerning characteristic of variable deceleration, they are following the rule of 60, they are deeper than 60 beat per minute drop or wider than 60 seconds. There is reduced the baseline variability. There is failure to return back to the baseline. Either there is tachy or brady or increase or reduce in the heart rate. There is abnormal shape like W shape and or absent of shouldering. Acute fetal compromise require urgent delivery and preparation in cases of bradycardia. If the heart rate is not restoring to normal within 3 minutes, prompt delivery is needed. Remember that you need it 20 minutes even if the base deficit of the fetus is 0. It will take 20 minutes to reach to 10. That's mean after 10, the fetus will enter to metabolic acidosis. So we have to run in cases of prolonged deceleration or bradycardia. Caesarean section may then become necessarily or instrumental delivery according to the situation of the labor. Fetal blood sampling not appropriate or during this situation, and expedition of the birth may be required. CTG developed to support documentation, so all the feature must be documented every 30 minutes in the first stage or every 15 minutes in the second stage. And as I elaborated before, you are working in a team. So if you tell me as obstetrician, I cannot do it every 30 minutes, I'm busy covering ER, covering ward, covering labor room, multiple patients, I will tell you there is a nurse midwife who is sitting beside the patient, hoping that we are reaching to one-to-one care, or even if you are having two-to-one care, this midwife, they can go and just develop their sticker ready template, and they can just click on the fetal heart rate on that sticker. So CTG is a method for assessing the fetal central nervous system integrity, which is highly sensitive to the oxygen, which is critical in the interpretation and the clinical management. CTG documentations, if we said we have to document it and the frequency of documentation, now we want to say what we will document. Remember that every paper of the CTG, whether electronic or paper, you have to, it have to be written on it, the date, the time, the woman name, and the ID number. And the review every 15 to 30 minutes should be signed, whether electronic or paper. Documented every CTG feature like baseline fetal heart rate, variability, contraction, deceleration. And as I said before, you start with the contraction so you will not forget it. Note that in the intrapartum events like vaginal examination, fetal blood sampling, any other intervention, the last, not the least, you have to secure your CTG paper in a safe place at least for 25 years. And if it's electronic, you have to be sure that it is transferred and it's secure by auditing these important things from time to time. Monitoring and interpretation and documentations, you have to document the baseline. What we mean, you have to write the baseline, variability, acceleration, deceleration, and contraction. In each documentation, all these 5 parameters should be there. So baseline, it should be between 110 over 160 or to 160, variability between 5 and 25, and acceleration, reassuring, indicated fetal well-being. Deceleration, if it is occur, you have to say, is it early, variable, late? You have to be specific. And monitoring the frequency, duration, and intensity of the contraction. Here is the nice guideline, and you can see the feature, reassuring, non-reassuring, and abnormal feature, white, amber, and red for each of the feature. What is the baseline, the variability, and the deceleration? We will tackle each one separately so you will understand it, then you can look to the whole picture. Baseline fetal heart rate, determining the baseline fetal heart rate by observing the mean fetal heart rate, excluding acceleration, deceleration over a stable 10-minute period. To assess any changes in the baseline fetal heart rate, comparing it with early CTG tracing or fetal heart rate recording later on. Sometimes we have difficulty to identify the baseline fetal heart rate, so you have to go back to the previous CTG or you look forward to the next CTG, and we will, during the workshop cases, we are going to explain this more and more. So the baseline fetal heart rate is either white, amber, or red. White baseline fetal heart rate, where it is a stable baseline between 110 and 160 beats per minute, whereas amber fetal heart rate is increasing in the base fetal heart rate of 20 beats per minute or more from the start of the labor or since the last review an hour ago. 100 to 101 beats per minute considered to be amber. Unable to determine the baseline is considered to be amber. Remember that when we are talking about 100 to 109, a patient who is post-term, they are going more toward lower than 110. And remember this, those patients, you have to have the criteria, which is absence of deceleration, good beat-to-beat variability, and if there is good variability and from the start of the CTG or you extend the CTG and still it's 100 to 109 beat per minute, considered to be amber. Not like the baseline, which is all the time between 130 to 140 and suddenly drop to 100. This is a bradycardia or shifting in the baseline according to the situation. But if it is from the beginning 100 or 100 to 109, then this is considered be the baseline of the fetus. Baseline fetal heart rate will be considered red if it is below 100 or it is above 160 per minute for 60 minutes. Now we are talking about the variability, and when we talked about the variability, we know that the variability they having especially the long-term variability have been explained the cycle of the variability. It's 3 to 5 cycle per minute, where the short-term variability it is the tic-tac or the zigzag pattern between one beat and other beat, and what we are looking in our eyes it's the long-term variability. The variability, it should be more than 5 and less than 25. If it is less than 5, in 50 minutes, then we will talk now about the white, and we will talk about the amber, and we will talk about red variability. Here you can see this is a white variability, whereas the variability is intact between 5 and 25 beats per minute, and it is white, normal, reassuring, whatever you want to call it. And here is the variability. It is less than 5 beats per minute for 30 to 50 minutes. If this reduced variability exceeding the 40 minutes, then you start thinking why this fetus is exceeding the 40 minutes. The sleep cycle of the fetus is 40 minutes. And if it is exceeding the 40 minutes, you have to stimulate the fetus. You have to put the patient in the lateral side, start the resuscitation process. Because if it's exceeding 50 minutes, it is not anymore amber, it's not anymore suspicious, it is pathological. The other extreme of variability, we talk about reduced exaggerated variability or saltatory variability. And once the variability exceeding the 25 per minute for up to 10 minutes, we will call it amber or suspicious. And if it is exceeding the 10 minutes, so it is not anymore amber, it is pathological. Keep in mind that this saltatory variability can occur with vulnerable cord or with excessive movement of the fetus. And remember the Vroeg's reflex, where the mother is in severe pain. This will be reflected on the fetal heart rate, and this will be saltatory variability. So once you give the Demerol or betadine with metoclopramide, the variability will settle down. So how we could differentiate it if this variability, saltatory variability, pathological, or it is more toward normal? The time, which is the 10 minutes, this is one. The other thing, if it's preceded by deceleration or bradycardia, then it is not anymore normal. It is pathological, or what we call amber, up to 10 minutes, and after 10 minutes, it is considered to be pathological. So reassessment, full reassessment of the patient should be done. Keep in mind that saltatory variability can be a significant sign with fetal hypoxia. Now, if this variability, reduced variability exceeding 50 minutes, it's not anymore amber, it is red. And if this variability exceeding the 10-minute excessive saltatory variability, then it is red. What we mean red, that mean we have to start resuscitation. If it's not started at the same time, we have to start the process of delivery. So if the patient's imminent delivery, instrumental delivery can be done. If the patient's not imminent delivery, then cesarean section should be done. Sinusoidal heart rate pattern, it is if it's exceeding more than 10 minutes. Sinusoidal fetal heart pattern, it is loss of short-term and long-term variability, and it is oscillation and auto sound from the SA node. So there is no sympathetic, parasympathetic reflex on these oscillations. So you will find it is just only the SA node sending the pulses, and it can be seen, and we will explain it later on. We'll elaborate more about it. Fetal heart rate acceleration, the presence of acceleration is good sign, and it's a reassuring feature and indicated intact fetal autonomic nervous system and reflected adequate fetal oxygenation and often associated with a fetal movement. Why? Because a fetus who is getting enough oxygen, he will move, he will blink, he will breathe, and this acceleration is coming from all these things together. So what happens if this fetus is under the effect of the hypoxemia? Then he will decide that, okay, let me reserve this blood for the vital organ. I'm not going to move anymore. I'm not going to breathe. I'm not going to blink, and you will find absence of acceleration. So acceleration are markers for fetal neurological response. Acceleration is defined by increase of the 15 beat per minute above the baseline lasting for 15 seconds. So rule of 15, 15 by 15, is this applied for all the gestational age? No. If the fetus is extreme preterm below 29 weeks, then we are talking about 10 by 10. 10 by 10 below 29 weeks will be considered acceleration, okay? And when we are talking the deceleration, also the definition, it is 15 by 15, but down. So 15 by 15 up for acceleration, 15 by 15 down for deceleration. Whatever is fitting this criteria, then it is acceleration, except in the extreme preterm we said it is 10. So the interpretation point, the situation and the meaning, acceleration present means generally suggestive fetal well-being, no acceleration but otherwise normal CTG, don't indicate fetal acidosis, repeated acceleration with the movement, even strongly evidence of non-hypoxic fetus, even if they find the variability it is reduced or the baseline it is it's not appropriate. So whenever we have a patient who has having borderline tachycardia or starting to having tachycardia, but there is good acceleration, that give me good reassurance. So the key concept, acceleration are marker of fetal neurological responsiveness and oxygen reserve, and not merely heart rate fluctuation. Now we are talking about the deceleration. The definition of the deceleration is dropping of the fetal heart rate 15 beats per minute for 15-second duration. Whoever fitting this, it is deceleration. We don't have to question the things. So it doesn't mean to be deep to consider deceleration. A lot of people, they said this is a what do they call it? They said this, it's just only a peak or an acceleration. It's not acceleration, it's a peak. But if it is fitting the criteria, then it is acceleration. If fitting the depths, what is depth? Either it is deceleration or it's not deceleration. If it is more than 15 beat per minute drop or wider than 15 seconds, then it is deceleration. You don't have to name the thing in different way. So an exception to this is that in the tracing of reduced variability and deceleration may be shallow, and the shallow deceleration, particularly in late shallow deceleration, is a bad sign. Consider the deceleration in extreme preterm is 10 by 10, not 15 by 15. Categorization for the deceleration in fetal heart rate, it's either white, and when we are talking about either there is no deceleration at all or early deceleration, which is mirror image of each other and mirror image of the contractions, or variable deceleration without concerning feature for less than 90 minutes affecting less than 50% of the contraction. And look to this picture. It is a lot of people, they will say this is an early deceleration. Actually, it's not an early deceleration because this is a variable deceleration with early components because they are vary in shape and they are not a mirror image of each other. Even if they are occurring with the contraction, they are variable deceleration with the early components, which is reassuring. Amber deceleration, we are talking about variable deceleration with no concerning characteristics for 90 minutes or more. What that means when you are talking about no concerning characteristic, no reflex, central nervous system reflex. So this deceleration didn't cause hypoxemia, they didn't elicit sympathetic or parasympathetic reflex. So this deceleration was not causing the hypoxemia for the fetus. So if this is the situation, variable deceleration with no concerning characteristic but exceeding 90 minutes, we will consider it amber. You have to re-evaluate your case. So what will happen if this variable deceleration with concerning characteristic? So it is either no shouldering or increase, decrease with baseline or W shape, all the concerning characteristic we know exceeding the 60 minutes, but this deceleration affecting less than 50% of the contraction. So if we are talking about the deceleration affecting less than 50% of the contraction for 30 minutes or more, why more? Because if it is affecting less than 50% of the contraction, that means there is at least 2 minute time for the recovery of this deceleration. So we didn't expect it, even if there is concerning characteristics, but the frequency of this deceleration less than 50% of the contraction, so I will consider it as amber. But if this deceleration with concerning characteristic affecting more than 50% of the contraction, so it's not, I wouldn't wait more than 30 minutes. Why? Because I didn't expected that less than 2 minutes will wash out all the base deficits, and this will lead to accumulation of the base deficit. So the timeline for variable deceleration with concerning characteristic affecting more than 50% of the contraction is 30 minutes. Late deceleration in over 50% of the contraction for less than 30 minutes with no maternal or fetal clinical risk factor such as vaginal bleeding or significant meconium or suspected chorioamnitis. So remember that when you are talking about the amber, you are talking about a patient low risk. There is no fetal growth restriction, there is no vaginal bleeding, there is no meconium stain. But if this occur, any of these feature of the amber occurring in fetal growth restriction, so it's not anymore amber, it is pathological. So if the same thing occurring with vaginal bleeding or meconium or chorioamnitis, this is not anymore amber, this is a pathological. So remember that you are not reading the lab, you are not reading the CTG, you are interpreting the CTG in keeping in mind the history of the patient. Red deceleration, repeated variable deceleration with any concerning characteristic affecting 50% of the contractions or more for more than 30 minutes. This is a red. What mean by red? That means we resuscitate while we are preparing for the delivery, whether instrumental delivery or cesarean section. Repeated late deceleration for more than 30 minutes or acute bradycardia are single prolonged deceleration more than 3 minutes or more considered to be red. Remember that bradycardia you have to run, because even if this baby is fully oxygenated with no increase in the base deficits, which is never been zero, it will be 2 to 4, but let us assume it's 0. From 0 to 10, it will require 20 minutes in bradycardia. That means you have to run to take the baby out before the 20 minutes to prevent the baby to enter to metabolic acidosis. After 10, every minute, it really counted on the fetus health. Additional consideration, take into account the longer and the later the individual deceleration, the higher the risk of fetal compromise, especially if the deceleration are accompanied by a raise in the baseline, tachycardia, or reduce or increase the variability. So urgent measure and review. Urgent measure and review, start the conservative measure and carry out the urgent obstetric review if deceleration lasts longer than 30 minutes in the presence of either raise in the baseline heart rate or reduced variability. Consider antenatal and intrapartum risk factors such as suspected sepsis, the presence of meconium, slow progress labor, or the use of oxytocin to determining whether expedition of the birth is necessary. If variable deceleration persists and other CTG change are present, obtaining an urgent review by an obstetrician as there is a risk of fetal compromise and acidosis. The last and not the least, contractions. And I always say you start with the contraction. A lot of time with a lot of CTG, and you will see a lot of example in the workshop, which you are going to see in the advanced CTG course. When you finish the basic, you will see that the contraction play very important role and have been missed by the obstetrician. So wide contractions, 3 to 5 contraction in 10. When we are talking about the amber contraction, we are talking about five or more contraction 10 minutes, leading to reduced resting time between the contraction or hypertonus. If deceleration are present, assessing their timing in relation to the contractions. Why 5 contraction? Why not 6? Why not 7? I will tell you. Remember that 2 minutes it's requiring for full wash out of the base deficit accumulation. So if you exceeding the 5 contraction in 10 minutes, then you are depriving the patient from this 2 minutes to wash out the base deficit, and you are exposing the fetus to accumulation of the base deficits, accumulation of the hydrogen ion, and the lactate will be increased and expose the fetus for hypoxemia. So is it a solo 5 contraction in 10 minutes? The answer is no. It's not solo. So when you are talking about intrauterine growth restriction, undiagnosed retroplacental reserve, low retroplacental reserve, and you give the patient oxytocin, augmenter, and at the level of 4 contractions, she starts decelerating. Shall I stop the syntocinon? Shall I take her for emergency cesarean? You need to reduce, even if the patient she reached to, you start augmentation and she reach for 5 to 7, 8 centimeter, and she start to reduce, decelerated, reduce this oxytocin, reduce this contraction, because she can tolerate with her reserve 3 contraction, but she cannot tolerate 4 and 5 contraction. So don't exceed 5 contraction, but doesn't mean that this 5 contraction is our aim and target. No, our aim and target between the 3 and 5 contraction, which is maybe differ from one patient to another patient. If there are 5 or more contractions in 10 minutes, then you have to conduct a full risk assessment and take a step to reduce the frequency of the contractions, explain in the situation to the woman, and ensure she receive adequate pain relief. CTG trace categorizations. CTG is the way the fetus communicated its well-being to us. So he is talking to us. Categorize the CTG tracing basing on the scoring of each of the 4 features, the contraction, baseline variability, and deceleration, as white, amber, and red. Normal, all the features, they are normal. Amber or suspicious, any one feature is amber, this making the CTG is amber. Pathological, 2 amber or 1 red. So what action would be done according to the definition of the CTG? So if you have normal CTG, extend your CTG. Remember, you have to talk to your patient, reassure her everything is okay. We are going to keep you. Let us go, move, and stop the CTG on and off, and mobilize the patients. Give her full meal. Suspicious CTG, amber, with no additional concern risk factor. Evaluate the patient history, risk factor, examination. If the previous CTG is normal and acceleration are present, it is unlikely that the fetus have acidosis. So explain the situation to the woman and reassuring her. Document the finding and re-evaluate her after 15 minutes. And hold on, don't give the patients any meal, and preferable to keep her on continuous monitoring. Restricted her mobility at this stage because we don't want to lose the situation when the amber changed to red and we don't know about it. So management based on the interpretation of the CTG, we said all the features, they are white, then it's white, then this is normal, reassuring, category 1, call it whatever you want. Then you stop the CTG and mobilize the patient, give her her meal, and after 20 minutes, if there is no concerning characteristic, you can repeat the CTG for high-risk patients. When we are talking about the amber, we are talking about a suspicious CTG. What that means, there is one normal feature, one non-reassuring feature, and two normal feature. That's in one amber, two normal. So how we are going to manage such cases? We have to look for the underlying cause. If there is a maternal fever or tachycardia, resuscitate the patients, give her paracetamol, give her hydration, put her in left lateral position, and avoid the supine position, and offer intravenous fluids or oral, increasing the oral fluids. You have to reduce the contraction frequency. If she's in oxytocin, you have to stop it. If she's not in oxytocin and the patient she's having hyperstimulation or a tetanic contraction, you can give her terbutaline 0.25 milligram. Inform the consultant, document the plan after the informing the obstetrician, and talk to the woman, inform her about the situation, tell her that she is having non-reassuring CTG. We are going to observe her. If the CTG became normal, then nothing to be done. If the CTG became abnormal or pathological, then action should be taken. Here we have the category what we call red or pathological or category 3. So what we have in this category, we have one abnormal feature or one pathological feature and two non-reassuring feature. One of these, either one abnormal or two non-reassuring feature, and the measure which you need to take, also look for the underlying cause. If the underlying cause is maternal tachycardia and you give paracetamol, IV fluids, the patient passing 60 minutes and still tachycardia, and action should be taken. Start conservative measure like informing the senior obstetricians, the consultant. Offer fetal blood sampling if it's available. Most of our hospital we don't have it. So the next step is to take action within 30 minutes. Meanwhile, while you are taking action, informing in ICU, informing the anesthesiologist, informing the consultant what you can do, you can continue the resuscitation. If the problem resolved, then no need to take an action. If the problem persists, then an action should be taken. As we mentioned that the red CTG or pathological CTG or category 3 CTG, this CTG is having two parts. Either there is a bradycardia, and the management of bradycardia different from one pathological feature and two non-reassuring feature. The bradycardia should be managed as acute emergency, and we have to move fast. So within 9 minutes, if the CTG improved and the heart rate went back to normal, then you have to re-evaluate the case by senior obstetricians. where a decision will be made upon just to wait and observe or to proceed for the expeditions of normal of the vaginal delivery, whether normal like instrumental delivery or cesarean section. And if the CTG persisted to be within 9 minute bradycardia, then the fetus will be taken for emergency cesarean section. So by 9 minutes, the patient should be on table and should be scrapped. Then you check the heart rate. If the heart rate is still bradycardic, proceed for whatever, either instrumental or cesarean section. If the heart rate recover, then you have to re-evaluate the whole picture and you will decide. Remember that if repeated acceleration are present with reduced variability or with any type of deceleration, fetal heart rate tracing should be regarded as reassuring. And the true early uniform deceleration are rare and benign, and therefore they are not significant. Most deceleration in labor, they are uh, variable deceleration. The pseudosinusoidal fetal heart rate pattern. These patterns show a less regularity in the shape and amplitude of the variability wave and the presence of beat-to-beat variability. Look to this picture in the top. You can see this is an artifact by machine, and in down you can see this is pseudosinusoidal where the short-term variability is intact. Look here for this pseudosinusoidal variability. You can see there is acceleration, and you can see if you magnify this picture that the short-term variability is intact. Thank you for your commitment for better obstetrical care.